breaking barriers and bridging the gaps between patients and doctors. Welcome to Brainstorming with the Docs and your co-hosts, Dr. Glenn Harrison and Dr. Kolby Condos.
All right, everyone, welcome back to this week's episode of Brainstorming with the Docs. I'm Dr. Kolby Condos, my co-host and co-conspirator, Dr. Glenn Harrison. What's up, buddy?
I'm doing great. How was your day? How's your evening going?
Good, man. Apparently, my kids had a little bit of difficulty going down, but I think that they are firmly asleep now, which is good. So
Speak quietly.
Yeah. We had a little bit of a long week at the Condos household because we had some visitors and everyone's routine's a little bit screwed up. So
sleep patterns that got thrown off?
Just a little bit. Did a lot of traveling and a lot of outdoor activities. So not the normal sleep regimen that we're used to. So we're definitely paying the price right now.
Yes. I believe it. So the topic today is kind of, it's a heavy one, right? It's a heavy one because it's not a simple situation.
No, not at all. And it's something that most commonly people know that they're being affected by it and they know they've been diagnosed with it, but they're not really sure about the intricacies of it as far as like what is the cause, what are some management options, is there anything that I can do on my own? And those are some things that we're all going to cover today. So we're talking about scoliosis. If this is your first time watching or listening to the podcast or the YouTube channel, thanks for watching. And hit like and subscribe and turn on notifications because we're going to continue to roll out content like this each and every week. And you never know when it might be pertinent to you. So without further ado, we're going to get cracking on scoliosis. So question number one, what is scoliosis?
Right? It's just lateral curvature of the spine to the side of the spine. Could be in the upper. Where do you usually see it? I usually see it mid-back, thoracic area.
Yeah, and there's usually a compensatory curve back the other way. Again, it can be kind of all over the place, but most commonly in that like mid-thoracic, and then with the compensatory curve. So, lateral curvature of the spine. The thing about scoliosis is there's varying degrees of scoliosis. So there's some people that have like a very, very mild to slight scoliosis that probably have, little to no symptoms. And then there's people who actually have really severe scoliosis where it causes like compressive forces on their organs.
Yeah.
So there's different degrees and variant like severities of scoliosis, but then a lot of people don't know that there's actually varying types of scoliosis. So one of them would be like a functional scoliosis, which is like where it's non-structural and it's not rigid. And what we mean by that is it's not like an anatomical deformity of like one of the vertebrae in your spine that's causing the curve. Those are called hemivertebrae. And what a hemivertebrae is when like one side of the vertebrae is like slightly is deformed. So it's smaller or it's wedged or it's like half a vertebrae and it looks like a triangle.
So going back to functional before you get into structural, because hemivertebrae would be more structural.
Yep, absolutely.
But going back to functional, how would somebody know if they have functional scoliosis?
Yeah, so functional is a muscular imbalance. So you can do, there's certain orthopedic tests you can do. One is called the Adams test, which is like a forward bending test.
So it changes by position.
Yeah, by position. So you'd look at like, what's the position, standing versus bent over. You'd look at
if the curve goes away in one of those positions, then it would be more functional, not structural.
Yep.
And that would be less severe.
Yep.
That's right. Yeah, providing there's still going to be some work done and it's not.
Absolutely. Yeah, you still want to correct it because it can become something more severe if it's like neglected.
That's right. So that's more functional, just to simplify. What about go back to the structural one? I know there's a lot to that.
Yeah. So the structural one would be like an anatomical variance, or like it's rigid, it's stiff, it's stuck. So one of the things would be like we talked about the hemivertebrae, which means hemi is half. Usually they look kind of like a pizza triangle where they make it, a wedge, and the spine kind of follows the wedge. So there's actually a curve because of the hemivertebrae. And then there's a compensating curve the other direction to try to compensate for the offset center of gravity. So those are kind of like two of the big ones. When we look at structural though, you can kind of break it down into like, there's several subclasses. So there's like, there's a genetic concomitant, which would be like adolescent and juvenile scoliosis and then infantile scoliosis. And that's just something that you'd have to investigate a little bit more thoroughly to try to figure out and see that you can get on top of it pretty quickly.
Then there's kind of the congenital, how what you're more born with, and that's where you get into the hemivertebrae.
That would be the hemivertebrae. Yeah, unless you had something like a fracture, which would be pretty uncommon to have a lateral fracture of your vertebrae, but it could happen. But yeah, most of the time, if you're born with a hemivertebrae, that's that wedge-shaped vertebrae that's going to cause the curve of your spine.
That's structural.
Yep.
What about the neuromuscular? I know you're in this world all the time, in your neurology practice or functional neurology. I want to dive into that because that's maybe a root cause, if there is, to some cases. Sure. To some cases.
So when you look at like scoliosis, it can be a muscular imbalance, right? And when you look at muscular imbalances, you have to differentiate, like, is this caused by like a lesion to a lower motor neuron or an upper motor neuron? And basically that means, is it like a peripheral nerve? Is it in the spinal cord or in the brain? And then doing an exam and stuff like that, you would differentiate that, but it can actually affect the tone of the muscles, which, can affect the direction that the spine is going. So if you have like a truncal lesion, then it can cause contracture of your trunk muscles, and it can actually cause rotation and lateral deviation of the spinal cord that way.
So just to kind of simplify it, we want our spine to be straight.
Yep.
And if we think of the spine as, I don't know, something that's bendable, a pipe cleaner, if those still exist.
Oh yeah.
and if we have really tight muscles on one side of the spine, but loose muscles on the other side of the spine, it's going to pull the spine, the bones to that side.
To the side of the tight muscles.
To the side of the tight muscles. And on the other side, they're going to be relaxed muscles. But then the spine is like a plant that always wants to grow straight, if we want to simplify this. So then there's going to be a compensatory curve.
Compensatory. You nailed it, dude.
On the other side. So then you end up with this S-type curve. I just want to create a little clarity when we talk about lateral and musculature and things like that.
Yep. Yeah, for sure. You're always trying to make gravity straight above your pelvis, right? So if you're curving to the right, the natural compensation is going to be the upper half is going to curve to the left because it wants gravity over the center of your pelvis.
Okay. Yeah. So that's and you were getting into upper motor neuron lesions. The neurological.
Yeah, that's where you can get like, so lower motor neuron would be like more like flaccid paralysis, which would be like lack of muscle tone. If you had an upper motor neuron lesion, it would be like spastic paralysis or spasticity. So it would be like incredibly tight. And then you can look at things like, neuromuscular, but it would be like genetic stuff, or, like Marfan syndrome. That's a connective tissue disorder. Ehlers-Danlos is also a connective tissue disorder. And then, you can have other genetic stuff that can also cause different types of scoliosis as well.
So there's genetic components, there's brain components of this. It's not as simple as you just have it.
Yeah, it's not just, there's a curvature of the spine. Well, then you have to look at, why is that? Do I have, is there an actual anatomical variance that I have a hemivertebrae? Did I have a stroke or a brainstem infarct or something like that? Now I have
born that way. Yeah. We're born that way.
Yeah.
So there's a lot of variation, like you said, a lot of differentiation of the types of scoliosis and the severity. And it should be diagnosed and not just it's scoliosis. And then we just wait.
Right. So if you get diagnosed with scoliosis, it's like, A, what's it from? B, what is the severity? And then C, what can we do about it? Right. It's not just, you have scoliosis, see you later. It's not like diagnosis audiosis where it's like, here's what you got. See you later. Have a good life.
Never heard that diagnosis audiosis. Yeah, that's so true.
So true. Like,
and then the onset, of course, you mentioned some of the onsets, but trauma, of course, that could do it with fractures. I guess that would be the biggest thing.
Car accidents, stuff like that.
And cancers and neoplasms as well. But again, you do the proper imaging, you're going to see it. You do the proper imaging. And there's some metabolic issues, which are kind of interesting. And I never really put that together with regards to scoliosis, like rickets.
Yeah, which would be like softening of your bones, right? So it could cause
compressive forces,
deformities.
Yeah. So there's a lot to it, I guess. And hopefully that's where we're able to establish a lot of different kinds, a lot of different causes, and it should be properly explored so the best therapies can be done with it.
That's it. That's if you take one thing away from the first part that we just talked about, is don't just take it as I have scoliosis. Well, why do you have scoliosis? That's the part that you want to investigate, because you want to make sure that we're applying therapies appropriately and making sure that they're the most specific therapies for you.
Yeah.
So who for one might not be.
So who's the highest risk?
It's really common in females. Yeah. Like,
I don't know if I've seen a male with scoliosis. I don't think I have.
I mean, I see a lot more like structural and stuff like that than you do. So I've seen, I think in the 6 years that we've been open, I think I've seen 2.
Okay. So females, and then also even before their first period, before menses. Right?
Yeah, it does. They can get it. I read this statistic. I wrote it somewhere. Hang on a second. Yeah. So before menses, there's a 50% progression, and then a less than 20 risk if it's after. So if you get scoliosis before you have your period, you're more likely to develop a progressive scoliosis than if you've developed it after your first period. Then it's less likely to progress.
Are they still screening for that in schools?
When I was in school, they did screen it. I don't know if they are yet. My kids aren't at school age yet.
Yeah.
Check back with me in like 4 years. I'll tell you.
But it's important, right?
Screening absolutely.
Screening early. So this topic is so important because, and as we were talking about it, it's a very frustrating diagnosis. There's different severities of it, so depending on the severity, but it's important because it can be, if you're listening to this and have been diagnosed, but there's not really dealing with any pain yet, well, that is great. And you can do everything that you possibly can to reduce the progression of this, or hopefully even put it on hold. But scoliosis is very dynamic. When the brain's playing into, when there's genetic factors potential, it's very dynamic. So it should be something that should be monitored very, very closely. And if you are listening to this and it is progressed a lot, well, that's kind of where we get into the different types of strategies, right?
Yeah.
Now we're assuming people have been, properly checked. Adam's test, leaning forward, standing straight, see if it's functional, if it's changing with position or not changing, or it's structural, or it's structural. If it's not changing, either way, there should be a primary involved, and they're going to do the proper X-rays and imaging and
well, and even the genetic testing, to make sure that it's not some genetic concomitant of it as well.
Yeah. So this is kind of your world, musculoskeletal. What are the strategies out there? I don't think they've changed too much.
There's a lot. So you can do some like neural rehab in certain, certain situations. There's a lot of bracing. There's EMS, which is electromyostimulation. You can do manipulative therapy. There's certain strengthening exercises that physical therapists use. In really severe cases, when they want to stabilize it and try to prevent it from, getting really, really severe, they'll do surgery and do rods and fusions and all sorts of stuff. Yeah. And, if you catch it early enough, maybe you can do something about it. So that's the importance of really checking early.
Yeah. Catching early, following and making sure there's no progression. Medical doctors are usually really good to follow up and keep an eye on, not allowing for progression. But remember, a lot of this can be the result of musculoskeletal, the muscles pulling the spine in different directions. So if you're paying attention to the nervous system, find a functional neurologist that will help work on these things with you. Work with someone that's going to keep the joints and muscles moving as much. So if you have tight muscles on that on one side of the spine that are pulling it, what do you want to do? You want to relax those as much as you can and activate the muscles on the opposing side. This isn't necessarily a cure, but it sure as heck is maybe one of the better management strategies. And that can be done in so many different ways. Right.
And that's stuff that you can do at home when you're educated appropriately.
That's right. When you're told appropriately that the strategies you need for your curvature, not necessarily someone else's curvature.
Yeah, it's not a one size fits all, right? Because what you're doing for one guy, if it's a different cause or onset, you wouldn't do the same thing for a person with a hemivertebrae as you would for someone who's got an upper motor neuron lesion.
Exactly. This isn't necessarily one of those things. You're like, okay, I have some scoliosis. This is a do-it-myself project.
Yeah. No. You're going to want some guidance. You're not going to go on Google and
way too much risk with not doing everything you can for this. And if it is somebody that's listening to this that that even had procedures and, rods and stuff like that, or that might be in the works, that their doctor said that's what the next step is. I personally know 2 females that actually have rods, and they are athletes. They're athletes. They're winter sport athletes. That's as far as I'll go with this to keep it anonymous. But they are like leaders in their sport, and around the nation too. And they both have rods. And they've been able to compete remarkably. So, what is it? Just rods, and that's the end of the story? No. All sorts of therapies they're maintaining. They're following their musculoskeletal efforts. They're stretching. They're training. They're doing everything to calm those muscles down that are being programmed to tighten. Mm-hmm. And look what they've been able to achieve. So once again, don't just, okay, this is it. It's a sentence. Not at all. Okay.
Yeah, there's so much you can do. So if you've got it, find the right help and get after it.
That's right. That's exactly right.
So if you got value out of this content and you would like us to continue to pump it out, we will do so each and every week. Again, hit like and subscribe and turn on notifications. If you'd like to get a hold of us, we have an email associated with the podcast. It's info@brainstormingwiththedocs.com. Or you can get on our websites. Mine is www.northlakescheropractic.com, or Dr. Glenn's is www.drgharrison.com. And yeah, stay tuned because we're going to continue rolling this stuff out.
That's right. Well, thanks, Dr. Kolby. I look forward to the next one.
Sounds good, bud. I'll talk to you soon.